Okay, I'm going to start the webinar today. Want to welcome everyone. We had a great number of people register, and so we'll hope to see people trickle in as the lunch hour gets started. My name's Anna Chodos. I'm so honored today to be presenting this launch of Dementia Care Aware and our webinar. I'll be presenting the information on the cognitive health assessment basics towards the end, but really excited to have you all be here and to have some incredible guests and some of the leaders in our state in healthcare and in care for older adults across the state. So would love to get started with their introductions and brief remarks. Excuse me, pardon me, I've got a very tricky mouse today. So our agenda, first of all, want to point out you can at any point find access to our resources and this webinar as soon as it's concluded on dementiacareaware.org, the recording of this webinar. But today we have a tightly packed hour with some remarks to start and then a presentation of the cognitive health assessment basics. So we'll start off with a welcome to this program from our office of the California Governor, Gavin Newsom, with Kim McCoy Wade, then from our California Department of Aging with Susan DeMarois, and finally our California Department of Healthcare Services, both from Jacey Cooper and Dr. Karen Mark. I'll introduce them all briefly again, and I look forward to being the one to tell you about the content of our cognitive health assessment towards the latter part of this hour. A quick mention about basics. We will be monitoring the chat and the Q&A. We really look forward to your input and questions. And just generally speaking, throughout this program, we really hope to be responsive and communicative with you as providers, as learners, as people interested in Dementia Care Aware. And so at the end, I'll be providing more information about how you can contact our program at any time. Of course, that information is also on our website. Okay, so let's keep going. I'm really pleased to be able to welcome Kim McCoy Wade, who has given us a few moments to talk about this program in the context of her work at the office of the California Governor, Gavin Newsom. And I think we were all really thrilled when she was appointed Senior Advisor on Aging, Disability, and Alzheimer's. And so thank you, Kim, so much for taking a moment to speak.
Oh, thank you so much. And good afternoon to all, and a warm and hearty welcome on behalf of Governor Gavin Newsom. This is truly a milestone day when we think back to the governor calling for a task force on Alzheimer's prevention preparedness and asking the former first partner, Maria Shriver, to chair it. And they came up with 10 bold recommendations. And then fast forward, the legislature's funding, 9 of the 10 are rolling out as California continues to lead the nation. And I wanted to share with you the governor's words at the time when he convened the task force. Too many of us, including many of us on this call, have seen the crushing grip this disease has on our loved ones, and especially on our wives and our moms. 2/3 of new Alzheimer's cases are women. That's why he launched the initiative and why he continues to support all the work here today and why I'm so excited. We know in California this disproportionately impacts women, disproportionately impacts Latino and Black women and men and families, and that all in all, as our state ages, 1 in 5 older adults will experience Alzheimer's or dementia. So it is with enormous gratitude to the Department of Healthcare Services and Department of Aging for your innovation, your commitment to equity, and your commitment to partnership with people like Dr. Chodos and so many others in California. That we are leading the way to truly be an age-friendly and dementia-friendly state for all. So congratulations on reaching this milestone, and excited to see what comes from all this great work. Thank you.
Thank you, yeah, for so much wonderful leadership in this area, and Governor Newsom's support and work as well. It's definitely an incredible time to be in California. Next, we're very pleased to have Susan DeMarois, who's the director of the California Department of Aging. And thank you, Susan, for saying some words.
Absolutely. Good afternoon, everybody. I'm so pleased to be here and whether, as we just heard from Kim McCoy Wade, whether it's the 10 bold recommendations from the governor's Alzheimer's task force or the 5 bold goals of the master plan for aging, today fulfills both of them. And it's so exciting to see the progress, the quick progress that has been made with the initiative, the Dementia Care Aware initiative, a collaborative between the governor's office, the Health and Human Services Agency, and of course, the legislature. And this was made possible with partnership with our federal partners in the Home and Community-Based Services spending plan. So congratulations. In terms of the California Department of Aging, I really like that it looks like the tagline for this initiative is early detection, better care. And we swoop in for the better care part. We're very excited to partner with all of you who are joining today, and especially with health systems and primary care providers to make available all of the resources in our state to direct people to and refer them to. Resources like our area agencies on aging, our Aging and Disability Resource Connection, the network of California Caregiver Resource Centers. And just this week, we announced new Alzheimer's Daycare Resource Center funding that will be moving across the state. We also offer health insurance counseling and advocacy, senior nutrition. So we want to assure anyone on this call that if you do participate in Dementia Care Aware and you do provide early detection to your patients and their families, that there are services and supports to assist them on their journey. And the California Department of Aging is a great place to start. So congratulations again. We look forward to continuing to be part of this and to follow the progress every step of the way. Great to be here, and thank you.
Thank you. I think we can really echo, and we will be echoing throughout the program, all of the incredible things that the Department of Aging does to support folks living with dementia and the people who are in their lives and supporting them. And probably a lot of the time we'll be recommending programs that come back to the Department of Aging without people even realizing it. And just thank you so much as well for your leadership. We are super pleased to also have Jacey Cooper, who's Chief Deputy Director for Healthcare Programs and our state Medicaid Director, at the Department of Healthcare Services. And as many of you have probably noticed, this is a DHCS program, and we are incredibly proud to be operationalizing that. And so really excited to hear from Jacey as well, how we can make this program a success.
Thank you so much. And thank you both, Kim and Susan, for your opening comments. I think you guys both have been huge champions of this work for a very long time, and appreciate all of your energy and passion in this space. DHCS is very proud to be launching the Dementia Care Aware, a very new, exciting initiative that will really improve the care older adults receive for their cognitive health and improve detection of Alzheimer's disease and related dementias. I can just say that I'm a huge champion of this work, being someone who lost a mother to Alzheimer's. And so I love that we're launching this today. I think it's amazing and really critical work that we must do. Dementia really affects daily functioning and is life-changing and leads to challenges in managing all facets of life, including our finances, our health, and our relationships. These challenges are that much more difficult for low-income Californians who often lack the resources and supports to navigate this diagnosis. We know that Californians, as Kim mentioned at the beginning of this call, are older adults who are low income, have more risk factors for dementia. Many adults in California, such as Asian, Black, and Latinx older adults, have much higher, often 1.5 or 2 times the rate of dementia compared to white older adults. At the same time, we know that they are less likely to receive a diagnosis at an early stage. That's why this work is so critical for us to charge and to move forward. And the passing of Senate Bill 48 really helped expand our opportunity to do that. With Medi-Cal, adding a Medi-Cal benefit that would really allow us to include an annual cognitive health assessment for Medi-Cal beneficiaries who are 65 years of age or older. So as of July 1st of 2022, providers who complete the Dementia Care Aware training will be eligible for reimbursement for conducting these cognitive health assessments. And we really hope that primary care will be the front line of dementia detection and care, and that this program reaffirms Medi-Cal's full commitment to strengthening age-friendly care for older beneficiaries. We do know that Dementia Care Aware will provide high quality training. We have partnered with amazing people to work and provide this training to providers on conducting cognitive health assessments. Through the website and practice support services, it will also bring critical resources and connections to providers across the state to do the assessments and to implement next steps in excellent brain health care for people living with cognitive decline or dementia. And so I'm very excited to introduce our next speaker because she's helping champion this work for us here at the Department of Healthcare Services. So I will turn it over to our medical director, Dr. Karen Mark, who will talk about some of the features of the program and the future of this initiative.
Thank you so much, Jacey. And I wanted to say just good afternoon to everyone, and also a huge thank you to Kim and Susan as well for their leadership and their support in this effort. And also want to acknowledge Dr. Anna Chodos and the whole UCSF team that's really just been a great partner in this. So if you want to go to the next slide. I wanted to just start off by giving a brief overview of the Dementia Care Aware effort. So as Jacey mentioned, this is really a training opportunity for primary care teams to focus on early detection and better care for our patients with dementia. Today is our first core training on the cognitive health assessment, and we're going to continue additional trainings that will roll out to address the cognitive needs of our beneficiaries. And then, as Jacey also mentioned, effective July 1st, 2022, we have a new benefit for Medi-Cal only beneficiaries who are 65 years and older. This is the cognitive health assessment. This has previously been available for persons on Medicare, but what's new is that now for Medi-Cal only beneficiaries, we can cover this as well. And this benefit that was made possible through SB 48 includes a requirement for training and for appropriate documentation and using the code 1494F. And this cognitive health assessment training that Dr. Chodos will talk about is the training that's required before billing for that Medi-Cal only benefit. But Dementia Care Aware is really so much more than this. It's really, as part of the Home and Community-Based Services Spending Plan, we're going to be focusing on all sorts of practice support activities because we know in order to really start a new screening program, we need to provide support to practices to really implement this into the excellent primary care that they provide. So if you go to the next slide, we have three major goals in Dementia Care Aware. The first being to rapidly improve the ability of primary care teams serving Medi-Cal beneficiaries to detect dementia and create stage-appropriate plans. The next, to tailor training and resources to Medi-Cal beneficiaries' needs. So we're really focusing on the special populations that we serve in Medi-Cal: homeless individuals, non-English speakers, those with serious mental illness or multiple comorbidities, individuals with disabilities, so that we make sure that these vulnerable populations aren't left behind. And then the third goal is to improve care and quality of life for people living with dementia, especially those who are at higher risk and those who are from communities, as was mentioned, that have historically and unfortunately experienced dementia care-related disparities, including the Black and Latinx communities and the Asian communities. Next slide. So this slide just goes over some of our planned activities over the next couple of years. We've talked about the training and on the cognitive health assessment, and really additional trainings that will be forthcoming. Monthly webinars, just the first many, additional modules for CME and podcasts. We'll also be reaching out to providers in all 58 counties, both in person and via virtual and other media campaigns. We'll be providing practice support, as I mentioned, starting this fall, including both a website with practice management resources, and a warm line for clinicians, virtual teaching conferences, and hands-on coaching for practices that want to implement this. And then finally, this has built into it an evaluation of impact, which we know is so important, looking at not just the uptake and usefulness of the training, but also how we can improve that detection and diagnosis and improve care ultimately. So with that, I want to turn it over to Dr. Anna Chodos, who will walk us through the cognitive health assessment. Thank you so much, Anna, to you and your team.
Oh my gosh, thank you, Karen. And thank you to all of our speakers for just kind of putting the context on this program, why it's so important, why we're doing all of this to really support Californians, particularly low income, who need early detection, could really benefit from connection to all the resources that are already there, that folks like myself who practice in geriatrics and in the safety net, have become very familiar with in San Francisco County, where I practice. And just from the perspective of this program, for those who are tuning in, and I've seen some comments that really get to the fact that we have providers out there who have tuned in, which I'm so glad about. We really want this to be useful. We want you to be able to contact us and get the education and support you need around dementia care and around social services and other resources. So that's why all of this is happening. We couldn't be more excited, and again, to meet the goals of our California Department of Aging, the governor's plan, and the Department of Healthcare Services to help them realize all of this wonderful work. So again, please be in touch with us and communicate with us about how we can work with you to meet your training and care needs and care connection needs for your patients. So I'm really fortunate to now have this last half hour, even 40 minutes, to go over the cognitive health assessment basics. And my role is going to be as executive director of this program for the scope of our activities. So here to serve, really here to serve primary care, here to serve our older adults in California, and just really excited for this opportunity. I have been working in primary care in San Francisco in our San Francisco Health Network, and in geriatrics is my specialty training. We have a dementia clinic to do the next step, next level evaluations as well. So this is what I do every day. And I'm very passionate about helping primary care feel that they can do this and that they can start to help detect and address dementia and all the symptoms that people have. So that was the place we were coming from in developing the cognitive health assessment. And so our training is 90 minutes. And so we have about 30 minutes now to go over some of that content. And so what I'm hoping you get from this is a really grounded sense of what a cognitive health assessment is and what the components are and how you would do those. There's a lot more in the training that you'll be able to get around why, why we're focusing on certain aspects of these assessments. There's a lot of cases. It's very interactive. We're very proud of it. We also welcome your suggestions for improvement. But I'm hoping today you just get the big picture. And as I give the talk, I really hope to be able to emphasize those areas that I'm hoping you really remember. So I'm going to try to activate your memory so you can really leave here with the take-home points. Logistics about our training, you can register for it on our website. And once you do, you end up going through to our management system, our learning management system, where you have your courses. Right now, there's only one course available. So we'll have many more as 2022 finishes up. But when you log in, you would see your dashboard and it would tell you how to get to your training. The training will be right below it. It'll look like this. It'll say my courses. As I mentioned, there's only one you can sign up for at the moment. And it's called Dementia Care Aware, the Basics. It's about the cognitive health assessment. This is a training Karen was referring to in terms of being noted as having done the training, so you can use that billing code, which I'll review at the end as well, how to use the billing code. But I wanted to make sure you knew that there is when you click the course, it'll lead you to actually 3 parts of the course. And just so you're not confused, it'll be pretty self-explanatory in the sense that you can't really progress until you've done one. But the introductory information, when you click on it, is just a PDF that comes up and you'll read that and it'll be considered complete. The bulk of it is, of course, our actual training, the 90 minutes. And then we want as many people to get CME or any continuing education credits they can. We're offering a variety of them, which you'll be able to see once you do the course evaluation. And so we hope that that's useful to you. I know it's always really important to be able to get continuing education credits where we can. But once you've done the module, that would close and you can just finish out the 3-minute evaluation to get the CME. And we're going to be sending people certificates every quarter. So look forward to getting your CME information so we can send that to you. Okay, so now begins the part of the webinar where I'm really just going to focus on what is in that training and what it highlights. And hopefully, unfortunately, you still have to do the training to get the credit and for us to register you as having completed it. So you can use our 1494F billing code if you wish. And we really hope you do. But fundamentally, this assessment could be used in a patient who is under 65 or who's Medi-Medi. There's not something specific about the clinical aspects of the assessment that make it unusable in a dual eligible or younger population that has symptoms. But much like the annual wellness visit, a cognitive health assessment is meant to be an annual assessment, essentially for people who don't already have a known diagnosis. It's meant to be very quick, a very quick check. Again, in the spirit of an annual wellness brain health check, looking at both cognitive and functional symptoms, as well as the person's support system. So you're going to hear me time and time again refer to these 3 components: cognition, function, support system. Those are the things that the cognitive health assessment is going to give you a quick check on for your patient. And we believe this is a start. This is just opening the door to what might be a diagnostic assessment that goes further and gets you to the point of diagnosing dementia syndrome in someone. But really, this is that quick, in some ways, annual checkup for the brain for your patient. The other thing that we're really encouraging is that this is a way to jumpstart brain health for your patient as well. So many people, especially if they have symptoms, especially as they're getting older, really benefit from what we call just a general brain health approach. And we review what that means as well, so that hopefully you can start that with your patients and start helping them sort of support their brains as best we can. I think it's important to ground ourselves in the definition of dementia, because I know for me, it always helps me be grounded in what information I'm looking for and why. So if I'm ever going to get to a place where I know that someone has dementia syndrome, I have to establish 2 things. I have to establish that there's evidence for a cognitive decline in at least one area of their cognition. In a moment, I'm going to review what the different areas of cognition even are. But so I have to sort of determine that they've had a decline in at least one area of cognition, and that it's new, that this is not something that's been lifelong. And same thing with function. So in my mind, I'm always keeping front and center, how do I know if they have a cognitive decline? How do I know if they have a functional decline? What information are they telling me? What information can I get? Let me forward here. The other thing I think many of us know and do very, very well, I know all of my colleagues really do a fantastic job with this, is the second there's a symptom or a concern for functional or cognitive decline, people do the next level workup, which is making sure there's not a behavioral mental health reason, medical reason for these symptoms that we could be treating or could explain what's going on. So while that's really, really important, I feel like this is something we tend not to miss. We tend to do this pretty well. Whereas I find it's harder to keep in mind that we need to be investigating what's going on with cognitive symptoms and potential decline and functional symptoms and potential decline. So again, that's where we anchored the cognitive health assessment. That's why it touches on both of those domains, because it's really the start to knowing whether or not that person might have dementia. The other thing to keep in mind is there's a lot of types of cognitive decline, and we have different classifications. So dementia, which I just mentioned, is at the level where this person has abnormal declines in cognitive functioning for their age and typically also for their educational level. Those are the things we sort of norm to or we compare to. So they're having an abnormal decline, which usually means they're having more severe symptoms happening more frequently. Or when we test them, and if you happen to be a neuropsychologist and you've done all the tests, they're falling out of the range of normal for their age and education level. So that's how you might know that they have an abnormal decline. And it affects day-to-day function. So I know I just reviewed that criteria, so here it is again. But how does it compare to these other types of cognitive decline? Well, one of them is what we call mild cognitive impairment. And we call it that when someone does have a serious decline in cognition that's within the range of abnormal or out of the range of normal, but it's not affecting their day-to-day functioning. We're not finding evidence that they're having functional problems. They may have compensatory strategies that they now need to use, but it's not causing day-to-day impairment. And both of those are considered within the sort of pathological abnormal range of cognitive decline. But we know with our older folks particularly, their brain is changing. All of our brains are changing, all of our brains are aging. But once we get to a certain age, some of those changes manifest as, I think, symptoms people will tell you about, complain about, report to you. But that is within the realm of normal. And what that means is if you did sit down and you did really involve testing, it would still be within the range of normal for their age. And then there's just some typical features of age-related cognitive decline that you might start to get more familiar with, and we mention it in the training, what's more in the range of normal decline versus abnormal decline. And again, a lot of times that has to do with how often it's happening and how serious it is. And again, a key feature is that it's not affecting function. Another thing I just want to make you aware of is terminology is changing. So technically, mild cognitive impairment and dementia are now mild neurocognitive disorder and major neurocognitive disorder, in part to remind us all that they're probably on the spectrum of a pathological process that's going on in that person's brain. But we are still using all these terms. So that's fun for us. We get to have lots of choices of terminology, but in the future, it may be that you're seeing mild neurocognitive and major neurocognitive disorder used more frequently. The other thing it helps to keep in mind is dementia is a syndromic term. It just means they have a cognitive decline, a functional decline, doesn't necessarily tell you why. And it's so as an umbrella term, it helps us and hurts us because it's not as specific as perhaps it could be. And I think as practice and diagnostic tools and treatments evolve, we're going to have to get more specific about what's going on underneath that dementia syndrome. But just want everybody to be reminded that it is a term that we can diagnose based on features of this syndrome, but we may or may not, very easily know what's the cause is. And Alzheimer's is the biggest player out there. It's the primary cause in most people. But vascular dementia is also very common, meaning injury to the brain causing neurodegeneration from high blood pressure or vascular injury from strokes, diabetes, the things that sometimes are referred to as microvascular changes, all of those kind of fall into that category. And then there are other kinds like Lewy body dementia, frontal to temporal dementia. And if we kept listing it out, we would have only about 90 more to list out. So it is really complicated in that way that we're looking for a syndrome, but then as all of us as healthcare providers and healthcare teams, we'd love to know what's really going on so we know how to really support that person. And maybe prognosis, a lot of things might change. We'll talk about that more in future trainings, but we just touch on this briefly during this training so that folks are aware. We're opening the door to understanding if there might be a dementia syndrome going on with the person. And later on, we'll be able to help you learn and emphasize different features of these different actual causes that are actually causing the neurodegeneration in the brain that is leading to the dementia syndrome. it's good to, I think, just keep it in mind, because using shorthand for dementia is very useful. It tells you a lot about how that person's doing. But at some point, we will want diagnostic clarity, or at least try to get there to understand, sort of really what is the underlying disease. The other point we make often during our training, and which I hope will be of comfort to you as a healthcare team or provider, is that we know this is so important because brain health is whole person health. The brain is, as JC mentioned, like a diagnosis of a neurodegenerative brain disorder or dementia can really change that whole person's life, the people around them. And so supporting them and supporting their brain health is supporting their whole person health. For one, I know as a provider, when I'm working with a patient who has dementia or a neurodegenerative disorder, that really changes a lot of what I'm doing around the rest of their care, because it's going to change how I can partner with that person to make a care plan. It may really simplify things. It may change prognosis or how I'm thinking about prognosis. But for me, actually, the really empowering thing, the thing I love about working with folks who are experiencing symptoms and who are working on a dementia diagnosis, is there's actually a lot to do, and there's a lot to do very early on that supports their brain. And I get to talk to them about that and really try to work with them to see what motivates them, what might be a good fit to really work on to improve their brain health. Our brains love a few things. They love to hear and see. They love to be with people, socially interact, be challenged. So social and physical activity, hearing and vision, those are things I really start to investigate and work with my patient to improve their overall health on. The other is medications. There's a ton of medications that have cognitive side effects that we're not as attuned to. I think a lot of us know about Benadryl and some bladder medications and antispasmodics or back spasm medications. But there's a lot of other ones that have cognitive side effects that we're not quite as aware of. And so being attuned to that, looking at medications, reducing that, allowing people to have more information about that so they can avoid certain meds, that's also a huge support to the brain to just get rid of that stuff. And then as primary care is perfectly primed to do and already excellent at, helping people meet reasonable diabetes and blood pressure goals, those things, when very poorly controlled, have a big impact on progression of any cognitive decline, as well as overall brain health. So that's a lot we can do and really frame for people as a brain health action. Okay, I know I've done a ton of background, a ton of setting this up. Now I would love to just put out there, what is the cognitive health assessment? So again, I always keep in mind, I need to figure out what's going on with cognition, with function, and then ultimately rule out if there's a medical or behavioral health psychiatric driver of the symptoms I'm noticing. So those are the elements I'm looking for. But what we recommend as a cognitive health assessment is 3 pieces. 1, take a patient history. This is often an incredibly brief question or even an observation of how their cognitive health is doing, if they have any symptoms. And I'm going to go into each one of these in more detail once I'm done reviewing the big picture. Use a tool. So the issue that we have with cognition and function is we have to sort of triangulate the information. We don't have a quick blood test. We don't have a quick imaging test that tells us for sure what's going on. So we try to get more pieces of information. So using a tool, sometimes those tools are for an informant or for not the patient, but they can give us objective information about how the patient is doing. So I'm going to present you some tools that you can use, all of which are very brief, all of which are validated. And then the last is establishing a person's support person or healthcare agent. And it may seem unusual to include that so high up in it. As I mentioned, very early, we're just opening the door to, is something going on? Are we going to further investigate this person's cognitive and functional health to see if there is, a dementia syndrome going on? But we think that as people who, regularly work with people with dementia, that knowing who that person's support system is, or the people who are supporting them in some way, they may be formal caregivers, they may be just people in their lives who don't really identify that way. And then sometimes people have formal healthcare agents. All of these end up being pretty important to actually working with the person to achieve goals around brain health and to support them just in general. So starting to establish that early and getting information about that is something we feel you can do pretty quickly, and helps to sort of start the process of incorporating that into care planning. Granted, some people don't have anybody, that's fine too. You would document that as well, but we're just putting it out there that the earlier the better. So for the first step, taking the patient history, as I mentioned, it may be that you're noticing a sign or symptom. So your team or you as a nurse in the clinic may be noticing that this person's really struggling with medications. Maybe you've known them for a long time. This is a new thing. Maybe where someone's noticing they're starting to miss more appointments, come on the wrong day. That is a sign that there may be a cognitive decline. The other is a really simple question. And again, for those of you who have done an annual wellness visit, this is very analogous. Many people get asked, do you or others think that you're having trouble remembering things? Or during the past few years, have you or others noticed changes in your mental abilities? That's a broader question because, as I'm about to point out, cognition is more than just memory. But these are questions that could be good starter questions. Again, it's not necessarily comprehensive, but it's a good quick biopsy, and many people, you'll catch them this way with these questions. So it could just be you've noticed something, and honestly, then you're like, check, did it. Notice that they're having a ton more trouble managing their medications, or keep making medication errors, or missing appointments, or you're having all of your patients do a quick screen with during the past few years, have you or others noticed changes in your mental abilities? On the staying healthy assessment for the senior version, I believe it's question 20 is one of these questions. So you could be using that as well if your practice is using the staying healthy assessment for Medi-Cal. And then document that they had a positive response. So, step one, done. I did want to take a moment to just mention, and we go through this in the training, so you'll have more time to sort of absorb this and think about it and learn about it. We think of cognitive domains as more than memory. So technically, if you look at the DSM criteria for dementia, it says a decline in one or more cognitive domains. And lucky for us, tricky for us, the brain, lucky for us as humans, the brain does everything. Tricky for us as clinicians, the brain does everything. So it can have a myriad of symptoms depending on which exact neurodegenerative process is going on or what's going on with that person. A lot of it is behavior, especially in younger patients. It may present first as a behavioral symptom, a personality change, when people's lives really start kind of going off the rails and they're not functioning as well. Maybe they were a high functioning person and now their business is struggling and all these things. Granted, a lot of reasons for that too. I'm not saying that's a perfect marker, but just to point out there's technically 6 domains, and we go over it and explain a little bit more so you can learn a little bit more about what might trigger you to think that this is perhaps a presenting symptom of a cognitive decline. Okay, and then I said use a tool. And again, the reason for using a tool, you will feel more confident that you have meaningful information about how that person is doing. We really recommend starting with the first row here, the patient, trying to get cognitive and functional information from the patient first. But sometimes you're busy and you're actually able to give someone who came with them a informant, a tool. And if that tool is positive, you now have great information to say, well, I'm going to have to work this up more. That's a positive screen. So some people really choose to have like a care partner or somebody who's with the patient do the 88 while they're doing, other things with the patient. I'm sure, you have plenty to do. But I just want to show you some options. So for example, you could do a GP cog. A GP cog was developed in Australia. It's like a mini cog with a couple extra questions. If you've never seen the mini cog is a 3-item recall, meaning 3 words. You tell the person and you have to recall, they have to recall it in a minute, and a clock draw. GP cog is very similar with 1 or 2 extra elements, like tell me a recent news item and what's the date today. Tells you how to score it. It's a direct cognitive screen of the patient. It's also a little less sensitive to education than some of the other tools that are out there. So that's why we really like the GP cog. Also has a ton of languages. The second piece of the GP cog is a functional screening tool you give to an informant. Again, they may or may not have one, but if they do, that might be an option. So that's one quick way to incorporate it, and tends to be a few minutes total to do. The other is, like I said, you might give an informant an 88 and just ask the patient about their ADLs and IADLs. That's what we mean by function. We review that in the training. I'm going to quickly review that here as well as soon as I'm done here. Or you could just talk to the patient and do a mini cog and then ask them about ADLs and IADLs. I realize giving you, as providers and teams, a lot of options may be extra cognitive work that you have to do, but we also really wanted to be sensitive to language concerns, your familiarity with some of these tools and comfort level, what you like to do. So just want to point out that we gave a lot of options, and we explained kind of the pros and cons of all these different options, but they're all really short. So we wanted to make sure these were short tools. And I'm going to show you an example in a case at the end. So then finally, quick review of functional abilities. What do we mean by that? What do we even mean by functional decline? There's a lot of things we do in life to function. We specifically mean activities of daily living, instrumental activities of daily living. And when we're asking patients about this, we usually say, how do you do these things, to get a sense of if anyone's assisting them? And then if they say yes, you know, oh, I get help in the bath. Somebody, you could say, well, who helps you? Just tell me a little bit more. You can get kind of that granular information. But basically the idea is, has something about this person's daily functioning in either of these areas really, has it changed? Has it changed in any way, and how? So that is the goal of asking about functional activities. And as you can imagine, if someone does have a neurodegenerative disease leading to a dementia syndrome, so they're having a cognitive decline and a functional decline, they often have challenges with things in instrumental activities of daily living before they start having challenges in activities of daily living. Granted, a lot of this is not always cognitively caused, meaning they have a physical issue or new disability, or even temporary, that's meaning they need more help in one of these areas. That's okay, we'll figure that out later, but in a quick screen, kind of getting a sense of how and how they do these things and if that's changed is sort of the idea. And then just a brief comment about the tools. When do you need an informant? I know we're sort of harping on that, and the person may or may not have one. The reason we encourage people to get some informant information at this stage, but definitely later as well, if you have to keep going with the evaluation, is that once someone has symptoms of cognitive decline, it's very, very possible that there are things going on or other areas in which they're declining that they're not aware of. And I think most of us have a good sense of this, that dementia inherently means the person may not have insight. So when possible, we want to try to get some information from an informant. Again, that may come a little bit later in the evaluation when you're really taking time to work with an informant or get more information. But probably the most important stage, if you're just doing this quick cognitive health assessment, is if the patient screen's completely negative, you may still be missing something. So that's when we really highly encourage you to use an informant, use one of the tools to just get a quick snapshot from an informant about how they might be doing cognitively and functionally as well. If the patient is screening positive, meaning on their cognitive screen or their functional screen, there's an issue, right? They're sort of you're noticing a decline or it's abnormal, then you're going to continue the evaluation at another appointment at a later date anyway. And so you could maybe leave the informant piece until then, or a more depth informant piece until a later evaluation. So I hope that is somewhat clear. And then the last piece is trying to establish the person's support system and healthcare agent. And as I mentioned, this just becomes so critical to supporting that patient, understanding that a very functional older person who you're doing this screen may be a little confused as to why you're asking all this information. But in our training, we really talk about why it's important to sort of understand these roles. We give you some language for how to ask patients about how you might be able to talk to an informant or someone in their life who supports them, and how to ask about if they already have a healthcare agent or not. My mouse is very excitable. So those are the key components. Taking a history, using a tool, and then documenting a support person. And in all those areas, we're really trying to get to what cognitive or functional symptoms might they be having. And then you're going to want to document, particularly if you're going to use the code 1494F. Again, as Karen mentioned, this is a great opportunity for folks who are 65 and older and on Medi-Cal only. If your patient falls into that category, there's nothing about the overall approach or the tools that is restricted to that, of course. But if you are going to use 1494F, there is some documentation required. And so the main piece, though, is just to document what you did for the cognitive screening tool. So if you use the GP cog or the mini cog, documenting that that's what you did, that you reviewed the results, and that the result was blank, whatever it was, that you've interpreted that to mean it's a positive screen, it's a negative screen, and that you disclose the information and what plan you have. And then that information has to be in the chart. So I'm going to go through a quick example. We have 12 minutes. This should take just a few minutes, and then I look forward to getting to some of the Q&A and questions. Again, I just want to thank you in advance for putting those in there. If we can't get to all of them, we will certainly do our best to address the questions and comments on our website and in future bulletins and things like that. But Mrs. Perez is someone who you will meet in the training as well. I've shortened her case, but really briefly, she's 72. She came to her appointment with her daughter, Anna, who lives with her. So it's good reason to think she might have some information about her mom or know how she's doing. You make an agenda with your patient for the visit that day, and then you add that you'd like to review her brain health and say, do you think you're having more trouble remembering things? That's the question you've decided to use with your patients. And she notes, well, I guess I have forgotten to pick up my grandson more often. It's like I sort of lose track of time. It's not that I totally forget. It's just all of a sudden it's later and I don't know what happened. You document, okay, positive symptom, forgets to pick up grandson, and you're like, let me use a tool. So you decide to use the GP cog. Anna's there, so you give Anna the page 2, which is her section. You do the GP cog with Mrs. Perez, and it's actually online if you want to fill it out online, and you can print it out as well. It's in Spanish, which happens to be Mrs. Perez's preferred language. And she gets actually a positive screen. She has a couple of errors, and it suggests that you should be getting the informant information. You're well ahead of the game. You already gave Anna the page 2 to fill out. But Anna, she fills it out and it comes back as normal. There's no concern for functional impairment based on her score. Interestingly, it's the same score. The pages are scored differently, but Mrs. Perez is not seemingly functionally impaired. So that means that's overall a negative screen, because functionally she's doing okay. She did have a couple errors on the cognitive part. If you're really thorough or really like working with dementia, you might still proceed and do more of an evaluation at a later date. But you could just note that the overall GP cog was negative as an overall screen. And then we get to the support person piece. You say, it's really nice that I had the chance to meet Anna today. Are there ways in which she supports you in your day-to-day life? She says, we support each other, go grocery shopping, and she helps me keep track of bills. Does she help with coordinating your medical care? She comes to appointments to support me, but I make my appointments and I follow up on my own. Is there anyone else who helps you with any of these things? Not really. Do you have a healthcare agent, someone you've designated to make healthcare decisions for you if you can't speak for yourself, like on an advance directive? Nope, I haven't appointed anyone like that. Can I document honest information in the chart as a contact for you? Yes. So that's just one way to sort of get at who's like supporting her in the day-to-day and with what. And then is there an actual formal healthcare agent? And these are all things you would want to document. Some of it, I know in our chart, we have an area where we can at least document formal contacts and healthcare agents, but often the stuff about who's supporting who is more in our notes or some other section of the chart that isn't quite as visible to everybody in the healthcare system. So it may depend on your opportunities for documentation. Then part of the billing requirement is to disclose or explain to the person what the results were. So I just wanted to give you an example of that. We give other examples in the training. So for example, you might say to Mrs. Perez, thank you for taking the time with me today to review your brain health and involving Anna in this visit. You mentioned that you've been forgetting to pick up your grandson more often. When we did that brief test, you had some difficulty, though Anna's report of how you're doing day to day does not suggest you have a serious problem at this time. I'll make note of this, and I have some suggestions to support your brain health. I appreciate that you also gave me information about how you and Anna support each other, and I made sure her contact information is in the chart. We'll also follow up on this every year or whenever you notice any new symptoms. So it's just a way to explain. I always explain exactly how I was thinking about it, which is you reported a symptom. I got some information. Here's what I think about that. And then thank you for giving me all this context. I've done this and that with it. As I mentioned, we give you a sort of jumpstart plan for how to do the brain health. Like we're going to check your hearing and vision. We're going to go over your meds. We're going to, give you resources for social and physical activity. And a lot of that can be sort of, a dot phrase in the wrap up part of your plan, for example, or just orders for hearing and vision if those need to be updated. But this is just a little bit of language, one example of how you might disclose so that you can, feel good that you pass on the information and also document that you pass on the information. So documentation for her may look like what she reported in your history, that on the exam you found these things, who the informant was and your interpretation of these results, that her support system is this, that again, this may be in a note or another section of the chart, and that you disclosed it and that you have this plan for brain health action and annual screening. So that is a wrap up of the overall picture, just to emphasize and hopefully reinforce that cognitive and functional decline are just the core of this assessment. This is how we know if we're ever going to get to a diagnosis of dementia. It's a syndrome diagnosis. Once we've sort of done the ruling out other pieces, which we will outline in next steps for the evaluation, and I know many of you already know, for me, the really third pillar is that support system in terms of really thinking through how I'm going to manage someone who may or may not, someone who's having cognitive symptoms, but definitely someone who has dementia. And again, I think of this as a spiral. I keep coming back to the same issues. How's their cognition doing? How's their function doing? How's their social support? And each time I go a little bit deeper, but every time I see them or check in, those are the things I'm kind of going back and back over. And that is why those are the three elements of the cognitive health assessment, to help you just start opening the door to each of those areas. And then this is a progressive scenario. If someone has dementia because they have a neurodegenerative process, you're going to need to go back over these things anyway to really get your hands on a good care plan for them as you go along. And the other thing is time is a helpful thing here. Time is a diagnostic. It helps us know if they are progressing. And that is one of the wonderful things about primary care is we really know our patients. We get to see them over time. That is more meaningful in the context of trying to help somebody who is living with dementia than any other test, is just knowing that person, having that longitudinal relationship and opportunity for assessment. So another reason why we just have to keep going back over these things. Karen mentioned this beautifully. We have so much coming for you. I know there's, this one training on the website right now. We did just kick off July 1st. So we are working furiously to do more training, development modules, and different ways of learning, as mentioned, like other webinars, other podcasts, and then all this practice support activity, which could really be up to the level of hands-on coaching for a practice to implement dementia care pathways in primary care. We want to hear from you. We want to be engaged so that we can be of the greatest service, and we will be constantly connecting to resources in different counties so that people can really connect their patients living with dementia and their support, the support people in their lives, to resources. I'm going to leave this up while I look at the Q&A. These are opportunities for evaluation. I don't know, it looks like people are putting, yes, so that it's also in the chat if you want to just claim your continuing education credit now. You'll also get an email after this is over to be able to claim it. And this recording will be on the website to so in case you want to watch it again, or if you're only caught part of it. So just thank you beyond measure for being here today. We're so excited about this launch and getting the opportunity to support primary care and early detection and better care for dementia. We do have a lot of comments, and I am going to, we have information, I just want to put out, we have information about billing for FQHCs versus other environments. So for the person who asked that. And then great questions about cultural competency, people who don't speak English. We're going to have a specific module on language. First of all, people who don't prefer English, or so it's like another language, obviously, but it's also a separate issue if you're discordant with, as a provider or someone who's doing the assessment with the patient. So some of us, right, obviously speak the same language as our patients, and others do not. And so those are separate issues and may require different resources. Let's see here. I have one hand raised. Let me see. Obviously, we're going to also try to emphasize, it's not always available in all counties, but emphasize when there's language appropriate or culturally appropriate resources, like different adult day health programs, caregiver resources, peer support groups in different languages, things like that. Of course, we're very aware that that's a super important issue. The cognitive assessment can be conducted by anyone, just needs to be reviewed by a billing provider, and that is most certainly NPPA. It's even, there are non-MDs or non-advanced practitioners who can document this. So that is outlined as well in the training as who is a provider. I'm sorry, I'm trying to make sure to get to this. We'll post the slides and this recording. Somebody points out that FTD is younger onset as well as different symptoms. Yes, we are going to mention the different types of presentations. That's why we broaden the definition of a cognitive symptom, because it's different neurodegenerative processes have different different presentations. But I just want to thank everybody for your interest, for your engagement. Again, please reach out if there was something we couldn't get to, and we really look forward to hearing from you. Thank you, everyone, and thank you once again to our very esteemed guests, if they're still here, and for putting the full support of the state and our other incredible programs for older people and those living with dementia behind this effort. Have a great day, everyone. Thank you.